When people think about trauma, they usually picture anxiety, panic, or hypervigilance. But according to decades of trauma research, including guidance from the American Psychological Association, SAMHSA, and international trauma frameworks, trauma does not always show up as fear. For many individuals, trauma shows up as numbness, feeling disconnected, flat, emotionally muted, not overwhelmed, just shut down. So this is an overview, for educational purposes only, of why trauma can present as numbness rather than anxiety, grounded in peer-reviewed research and clinical consensus, and how trauma-informed therapies, including Brainspotting, are sometimes integrated to support recovery. Please note this is not therapy or treatment advice, but an educational discussion informed by reputable psychological science and sources such as clinical journals and research studies. All right. Numbness is a recognized trauma response. One of the clearest findings in trauma psychology is this: there is no single trauma response. The APA Dictionary of Psychology, SAMHSA's Trauma-Informed Care Framework, and international diagnostic literature all describe trauma response along a continuum of nervous system activation. On one end, anxiety, panic, hypervigilance. On the other, emotional numbing, shutdown, dissociation, freeze response. Research on PTSD and complex trauma, including studies summarized by the APA, shows that emotional numbing and detachment are core trauma symptoms, not secondary or avoidant behaviors. In other words, numbness is not less trauma, it is trauma expressed through hypoarousal. So, the neurobiology of numbness. Neuroscience research cited in APA publications and journals such as Biological Psychiatry and Journal of Traumatic Stress helps explain this pattern. When a threat is chronic, overwhelming, inescapable, the nervous system may shift away from fight or flight into shutdown. This involves reduced limbic activation, altered prefrontal limbic communication, endogenous opioid release that blunts emotional pain, narrowed awareness, and reduced sensation. This response is commonly observed in complex PTSD, developmental trauma, chronic relational stress, repeated emotional or identity-based injury. The World Health Organization and APA both recognize this as a protective survival response, not a pathology. Numbness is the nervous system choosing survival over sensation. So why is numbness often misunderstood? Because numbness does not look dramatic. It's frequently misinterpreted. People are often told, you look depressed, you're disconnected, you're avoidant. But research on dissociation, including work referenced by the APA and the International Society for the Study of Trauma and Dissociation, shows that shutdown responses are especially common when trauma occurs early, repeatedly, or without escape. Importantly, many individuals with numbness understand their trauma intellectually, can explain their history clearly, yet still feel emotionally absent. This aligns with research showing that trauma is often stored implicitly and somatically, not just verbally. So, why talk therapy alone may not shift numbness? So, talk therapy is strongly supported by research for insight, meaning-making, relational repair. However, APA summarized trauma research consistently notes that top-down cognitive approaches may not sufficiently engage hypoaroused or dissociative states on their own. This is not a failure of talk therapy. It reflects a mismatch between verbal reflective processes and nervous system states that operate below conscious awareness. This is why trauma-informed care increasingly emphasizes bottom-up processing, somatic awareness, nervous system regulation. Brainspotting is often discussed within this broader shift. So, brainspotting. Brainspotting is a trauma-informed therapeutic approach developed by Dr. David Grand, influenced by research on eye position, neural activation, and somatic processing. Peer-reviewed studies published in journals such as Medical Hypothesis and Journal of Psychotherapy Integration suggest that brainspotting may reduce subjective distress and trauma-related symptoms, particularly when those symptoms are somatically held or difficult to verbalize. However, and this is critical for accuracy, unlike EMDR, which is formally recognized by the APA and World Health Organization for treatment of PTSD, Brainspotting's research base is emerging, smaller, and still developing. Most professional literature describes it as an adjunctive approach, not a standalone treatment. So why is brainspotting relevant for numbness? Numbness presents a unique clinical challenge. There may be little emotional activation to describe. Verbal processing may feel inaccessible. Brainspotting is sometimes integrated because it does not rely on detailed narrative recall. It works with subtle internal sensations, allows activation to engage and emerge gradually. This aligns with broader trauma research showing that procedural and implicit memory systems often require nonverbal access points. Again, research does not suggest this works for everyone, but it explains why clinicians may integrate it thoughtfully for shutdown states. So how does this integrate into ethical practice in therapy? The most evidence-aligned way to frame brainspotting is this. It may support recovery for some individuals. When integrated into a licensed therapist trauma-informed treatment plan that incorporates measurement-based care alongside approaches with stronger evidence bases, such as dialectical behavioral therapy or cognitive processing therapy or EMDR. This framing is consistent with APA ethical guidelines, which emphasizes assessment, informed consent, scope of competence, and individualized care. No single modality treats trauma comprehensively. So where to get help? If numbness, dissociation, or shutdown resonates with you, consider seeking support from a licensed mental health professional in your state who practices trauma-informed care. Reputable organizations such as the APA, SAMHSA, and ISTSS recommend working with clinicians who understand dissociation and hypoarousal, can explain how different approaches are integrated into care, and tailor treatment to the individual. So this video is for educational and informational purposes only. It is not therapy, diagnosis, or mental health treatment. The information shared is based on peer-reviewed research and guidance from reputable organizations, including the American Psychological Association. Brainspotting and other trauma-informed approaches should only be provided by licensed mental health professionals and are not standalone solutions. Please consult a licensed mental health professional authorized to practice in your state if you are seeking care. Numbness is not the absence of trauma. It's often evidence of how well the nervous system learned to survive. Understanding that opens the door to compassion and to evidence-informed support.